Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. When we are monitoring a fetus, we are looking for several things that give us an indication of fetal well-being. One of the most concerning things we can see during this time is late decelerations. Late decelerations are an indication of placental insufficiency that can lead to hypoxia for the baby. When we see a late deceleration, we can identify it based on the timing related to a contraction. So in this example, you can see where the late deceleration begins after the contraction starts and it ends after the contraction has ended. So on the bottom graph, these are our contractions. And on the top graph, this is the baby's heart rate. So this is the baseline, and here's our decrease from the baseline, and then the return to baseline. And you can see here that here is the beginning of a contraction, and here's the beginning of the deceleration that happens after the beginning of the contraction. So the key word to remember for this is after. If it happens after the contraction, that's an indication that it is considered late. So here's the nadir of the deceleration here, which is the lowest point, and this is happening after the peak of the contraction here. And then at the end of the contraction here, the deceleration is not coming back to the baseline until after the contraction has ended. So this is what a late deceleration would look like. When we think about late decelerations, we think about placental insufficiency. So if you learned veal chop, the L of veal is late, and the P of chop is placental insufficiency. We also can call this uteroplacental insufficiency. But what does that mean? Why is the placenta insufficient? So we need to think about how the placenta does its job, and we need to think about perfusion. So during a pregnancy, things that can affect the placenta's perfusion can be related to chronic issues. If she is a smoker or she has preeclampsia, these are things that can cause chronic vasoconstriction or vasospasm, and this can affect the way that the placenta is perfused over time. This leads to smaller babies that we call IUGR, intrauterine growth restriction, and this is because they have had a long-term effect on the oxygen and nutrient status for the baby. But in labor and delivery, we're looking at a more acute condition. So we're thinking about how the placenta is being perfused currently. And these are typically related to position, blood pressure, and contractions. So anytime the fetal heart rate decelerates after the contraction has begun and doesn't return to the baseline until after it has ended, like we looked at, the placenta did not have adequate perfusion to supply the baby with oxygen during that contraction. So we're thinking about how to improve perfusion and improve oxygenation to our baby. If we're not able to do so, the baby is at risk of becoming hypoxic and we might need to have a cesarean birth. So first we're going to think about position. Think about supine hypotension. If she's laying on her back, the weight of the uterus and the baby are putting pressure on the vena cava. Pressure on the vena cava decreases blood pressure, and this is going to affect placental perfusion. For blood pressure, another thing that can cause the blood pressure to be low can be things like an epidural. If the blood pressure is low, we're not perfusing the placenta well. Contractions. Every time the uterine muscle is contracting, the vessels that are coming through the uterine wall, through the endometrium to the placenta are being compressed. Okay, so we need to think about these things and address them. And thankfully, we can intervene very minimally to get a big result on a lot of these things so that hopefully we don't need to do a C-section, but sometimes we will need to so that the baby does not become hypoxic because this can cause brain damage and death. So let's intervene. So let's think first about our position. This is going to be the good first thing to do. It's quick, it's easy, it's non-invasive. We're going to think about supine hypotension or vena cava syndrome can cause that blood pressure to go down. And so you can see here, you can see the aorta and the vena cava and the big uterus with the baby inside. If she's on her back, there's a lot of weight on those vessels. At term, the blood flow to the uterus is about 600 mLs every minute. So even a mild decrease in blood return can have a significant increase on circulation. So if the mom is on her back, we have pressure on the inferior vena cava. But if we turn her on her side, you can see the difference between the pressure on the vena cava and the aorta versus how the pressure is relieved just with a position change. So position change is the primary management to relieve pressure on the vena cava and improve perfusion. So we're going to, first thing, we're having late decelerations. I'm going to reposition the mom. Okay. The next thing we need to think about is blood pressure. So the placenta relies on mom's blood pressure for adequate perfusion. If we are giving her a regional anesthesia, if she just got an epidural, or also if she's getting a spinal placement, if she's having a C-section, all of these things cause vasodilation and can cause hypotension. So for someone that we know we're going to be doing these things for, we'll do a fluid bolus first to help support mom's blood pressure and maximize uterine blood flow. However, if her blood pressure is low afterwards, she might need additional IV fluids in order to help support her blood pressure. And then the contraction. So whenever the uterus compresses, it's decreasing blood flow to the placenta because the maternal endometrial arteries and vein run through the muscle of the uterus to the endometrium. Okay, so when the uterine muscle squeezes, then we're getting pressure on these vessels. Okay, so this is the other thing we think about. So there's very little maternal blood flow through the placenta during the peak of a normal contraction. However, there should be enough oxygenated blood in the placenta to sustain until that peak of the contraction has ended. If the contractions are too frequent or they're lasting too long, we're not getting enough time to replace with fresh maternal blood that's oxygenated in between contractions. So this is where contractions can also be a concern. So if she's on oxytocin to help her contractions be stronger or closer together, we can turn that off. We could also consider giving a medication that will slow the contractions down. And so we call this a tocolytic, and the tocolytic of choice for this is terbutaline. So this is the point. What are we going to do if we are seeing late decelerations? Remember, we don't want our baby to be hypoxic. We need to intervene. So let's reposition the mom. We can give oxygen as an option. If mom herself has low oxygen level, then giving oxygen will help the blood that is being perfused to be better oxygenated. This used to be one of the big steps for what we call intrauterine resuscitation, but it's not the priority anymore, but it is still in the list. Okay. IV fluid, let's support the blood pressure. Notify, we might need a cesarean delivery if the pattern's not improving due to the hypoxia risk for the baby. So we need to let the provider know when we're having late decelerations. And then we can also, T is for tocolytics to slow contractions down and turning off oxytocin to decrease the frequency, strength, and duration of contractions. So these are the steps to remember when we see late decelerations. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.